Good morning, everybody. My name's Dr. Bruce Watts. It's December 2023, and we're just going to be having a look at how to look after an indwelling catheter today, a urinary catheter. Siting the catheter is really important. It's not our topic today, but the general principles are don't put one in if you don't have to. Make sure it's put in a sterile way, and when you put it in, make sure you have a plan for removal, a time that you're going to do it. Make sure you've got good light, sterile field, good trolley. It really does help to have an assistant, and positioning the patient is really important, particularly for ladies. A sacral cushion makes a big difference. When you're electing to site a urinary catheter, just have a think about the complications, particularly infection, sepsis, blockage of the catheter, creating strictures in the urethra. Sometimes bladder stones can be caused by a catheter, and occasionally there are more serious complications like bladder perforation or a fistula formation. When it comes to catheters, you've probably seen the Foley catheter is the general thing that's used. Been around for a long time, nearly 100 years. It's generally given a sizing called a French gauge, and the French sizing is just the outside diameter of the catheter multiplied by 3, so that's the diameter in millimeters. So as a general rule of thumb, a 12 is a small catheter, 14 to 16 would be a sort of common size that you use, and the 18 to 20 size is a fairly large catheter. Anything bigger than that would be something you would use in urology or after surgery. With the balloon for your catheter, we're just going to have a quick talk about those. Don't overfill the balloon. There is a risk of rupture, and sometimes the fragments of the balloon can be retained in the bladder. When you fill the balloon, use water for injections, not saline. There's a small increase in the risk of blockage in the channel that feeds your balloon if you're using saline. Balloons tend to lose a little bit of their fluid volume over time. So if you put 5 mils in a balloon and check it in a month's time, commonly it will have 4 mils left in it. So it's not a bad idea to check them every now and then and make sure that they're not emptying slowly and the catheter isn't going to fall out. Sometimes the balloon will have a bit of difficulty coming out. There's a couple of things you can do. I'm just going to show you the balloon here now. So I've got 10 mils in the syringe, got my Foley catheter here, and what we're going to do is blow up the catheter balloon. So that's 1 mil. That's 3. That's 5. And that's the common amount that I would put in a catheter. The catheter itself says you can put 10 mils in it, which is a lot of volume, but it's unnecessary, and 5 to 7 mils is plenty in a balloon. If you overdistend it, you can increase the risk of the balloon rupturing. When you take the water out of the balloon to remove the catheter, you'll see that it comes out nice and slowly. Quite commonly, when it gets down to 0 and it's really empty, if you look closely at it, you'll see that the catheter balloon actually develops some ridges in it. Sometimes they're circumferential, sometimes they're longitudinal, and the ridges can be painful when you try and remove the catheter, whether it's suprapubic or whether it's urethral. You can get around that a little bit by just putting around about 0.1 of a mil of water back into the balloon, and that's enough. And what it does is just smooth out the ridges, just give it a slight cigar shape, and it's often a lot more comfortable for the patient when you remove the catheter. If the balloon is actually blocked and you can't get any water out of it and the catheter won't come out, it is possible to actually snip this bit off. So you get your scissors and just cut that off right there. And most of the time the balloon will just drain. Occasionally it doesn't, and if it doesn't and the catheter won't come out, you need to have an ultrasound and you need help from a urologist. All right, moving on, drainage bags. So drainage bags are really important. If you're using a leg bag, which is the most common thing, it should be positioned on your inner thigh or calf. It's really important that the drainage bag always stays lower than the catheter. So what you don't want is the drainage bag to be making urine run back into the catheter. Generally speaking, you want to empty the drainage bag every 2 to 3 hours or sooner if it's getting heavy or full. When you do change the drainage bag, you need to make sure that you do it in a sterile way. Pinch the catheter just so you don't have any leaks when you're changing it. And the old rule of thumb is make sure you bring the bag to the catheter, not the other way around, or the patient will not be happy with you. The old bags are generally emptied just into the toilet and then thrown into the rubbish. When it comes to overnight, you want the patient not to have to get up all night and have a full bag everywhere. So we usually would connect a overnight leg bag, which is up to 2 litres of volume, or a bottle. And you want to just make sure again that it's not overfull, and make sure it's not over high and refluxing into the bladder. So generally speaking, a night bag should be put on a stand or in a container. The night bags are actually reusable, so you can use warm water and a small amount of soap just to wash them out and rinse them out. Typically we rinse with water with a tiny bit of vinegar in it just to reduce the odour in the bag. And then if you hang that overnight bag up, let it drain with the tip in a clean way off the floor, it can dry out and be reused. Another option with your catheter will be a flip flow valve or a catheter valve. So this valve actually is like a tap that attaches to your catheter. You can leave it closed until you're ready to empty. So the patient, particularly if they have a suprapubic, can put the tap on, close the valve, and just tuck the catheter inside their underwear. Go out to the shops, have their outing, not have a leg bag with them. And then when they're ready, they can release that into the toilet. Usually with a flip flow valve, we would get the patient to have an overnight bag at night time just to prevent them getting up all the time. So catheter valves and flip flow valves generally suit patients with intact sensation and cognition, difficult for someone who's not able to manage all of that. So what about trying to prevent infection and treating infection? So general principle is you want to remove the catheter as soon as you can. So if you remove the catheter on the first day after an operation on the bladder, the infection rate is significantly lower than if you wait till day 3. So the sooner you pull it out, the better. Anyone who's got a long-term catheter, you want to take the time every now and then to have a look at, do they really need it? Could they have another trial of void? Is there a reason preventing them having the catheter out? So regularly reviewing the need for a catheter is the most important thing. Most studies show that a closed drainage system is significantly better at preventing infection. So that's with the catheter bag, with or without the valve. Managing the emptying and the washing with clean technique makes a big difference. How should you manage the entry point where the catheter goes into the urethra? Generally, the guidelines are to use a little bit of mild soapy water, but not antiseptic. So around a suprapubic catheter site or around the urethral meatus, just a gentle wash, try and get away any crustation or biofilm that's there, and then a little bit of a rinse with some clean water, and that's it. You don't need to apply antibacterial solutions or betadine. In fact, a number of studies show that that tends to increase the bacterial resistance and is unhelpful. Every catheter that stays in long enough will become colonized with bacteria. So it's thought that about 5% per day. So at the 1 month mark, 95% of catheters and bladders are significantly colonized with bacteria. And at that point, there's not a lot of value in doing a urine dipstick because it will always show positive. There's also not a great deal of value in doing a lab microurine because it will nearly always grow something, commonly a mixed group of organisms, and it doesn't help you decide what to do about that. Generally speaking, you want to try and avoid giving the patient antibiotics. It's not routinely helpful. So a general principle with that would be if the patient has a high temperature, if they've got a lot of bladder pain, if there's bleeding, if they've got signs of sepsis elsewhere in the bladder, or there's, in a dementia patient, sometimes a really significant behaviour change, may be an indicator that there's an active urinary infection there. Otherwise, you're better off not to actually give your patient antibiotics, and routinely dipsticking the urine in a patient with a long-term catheter only creates headaches and problems, and it's better not to do it. Every now and then you may see a urinary catheter or drainage bag that goes purple or grey. That's called purple urine drainage bag syndrome. It's actually thought to be due to the production of a couple of enzymes, sulfatase and phosphatase. They break down certain components in the urine, which then react with the synthetic components of the catheter and the bladder drainage bag. And they produce this kind of indigo staining of the tubing. If you actually get a bit of urine out of it and look in the jar, the urine looks pretty clear. It's just the bag and the catheter that have gone dark, and it can be a little bit weird looking, or the patient may feel like, gosh, what's going on? It's a little more common in women, a little more common if people are constipated. It's thought that that might change the way bile salts and bowel flora are affecting the bladder. In and of itself, it's nothing particularly to worry about. People have used a few different things to try and reduce it. Classically, antimicrobial strategies, irrigation, changing the catheter frequently have routinely not been particularly helpful. Some patients get it and most patients don't. What should you do if your catheter's leaking or bypassing, as in the patient is passing urine around the catheter? First of all, check for kinks or blocks. Make sure there's nothing that's actually stopping the flow of urine. The most common cause is encrustation, so bacterial biofilm develops crystallization within the catheter. Then the flow starts to slow, and eventually it will kind of intermittently block. Once that's happening, generally speaking, you're going to need to replace the catheter. If it's happening really commonly and there's a lot of bypassing going on, even when the flow is okay, there can be value in increasing the French gauge of the catheter. So typically by 2, if you've got a 14 in and it keeps blocking, resite with a 16, etc. There are some commercial products out there that are available to irrigate a catheter, the theory being that it will reduce the bacterial load and the crystallization and colonization. One that's probably best known in Australia is CBG, which has a chemical in it called PHMB. And what it is a little bag, 100 ml bag, that you just passively run with gravity into the catheter directly. You wait for 5 minutes and then reconnect the catheter bag to the drainage system and just let it all drain out again. There's limited evidence that it's of any value. I would generally not use something like that unless it was recommended by a specialist. It's typically done 2 to 3 times a week in a patient for whom it may be appropriate. A lot of guidelines suggest that it's not helpful and that it doesn't reduce bacterial colonization. Another factor in encrustation inside catheters is urinary pH, so the acidity, and it's a little bit tricky because the more alkaline the urine, the more likely you are to get some encrustation. But perversely, taking citrate type things like urale can actually reduce the encrustation a little bit, because a lot of the encrustation is thought to be due to ammonia from urease producing organisms. So worth consulting with the doctor about that, but it can be trialled. The evidence for its value, having regular urale in a patient with encrustation, is marginal. If you have a patient who's drinking very little and the urine throughput in the catheter is quite small, the urine is going to be more concentrated, and then the patient is more likely to get crystallization and blockage. So next question would be, should you change the catheter regularly on a routine schedule? So some guidelines around the world say no, don't do that. In fact, it increases the risk of infection, and a complete closed system that's not accessed except in a sterile, clean way to change bags may actually reduce the rate at which you get a urinary infection. So the CDC in America and up-to-date guidelines suggest not routinely changing a long-term indwelling catheter or suprapubic catheter. But many guidelines in Australia, including Queensland, New South Wales Health, have a routine schedule of 4 to 6 weeks for changing. And the logic behind it is that you can reduce the rate of blockage. You may have a cleaner catheter with a lower microbial load, although that tends to only be for a day or two after the catheter change. A patient that you know blocks up readily and is prone to encrustation, it is better generally to have a regular schedule for changing their catheter. So with urinary catheters, just make sure that you're doing everything in a sterile way. Make sure that your drainage and gravity is preventing reflux, and make sure that your patient is getting a change when they need it, and if they don't need it, try and avoid that. Thanks for listening.